Okay, we can have the first slide for like a very brief introduction of what we are going to be talking about today. I think it's very clear that we are living exceptional times in the sense like there's like a new wall in the making while we are witnessing like historical transformations. And when it comes to European Union or like European context, we are facing what we can consider transnational policy matters, like issues that governments by itself cannot confront or address. And I think that particularly is the case with medicine shortages, high prices, and also unmet or unforeseen health needs, like in the case of like future pandemics, for instance. Same time, this is combined with like global trends that have been going on for some time now, at least a decade, especially when it comes to the concentration of pharmaceutical manufacturing in certain like geographical locations. Especially, we witnessed like a process of deslocalization of pharmaceutical factories in Europe in the 90s, and there was like this movement towards like China, and now we are seeing that like the authorities, both at the national level and European Union, are trying to reverse this tendency. Especially, there's this like realization that there is a dependency and like that supply chains might be disrupted in such a way that can really affect public health in the European Union. Also, we've seen how the role of IP in the biomedical research and development model has grown exponentially in the last 10 years. It's now not only like an integral part of it, but also a leading force in the sense that like the patent portfolio has become like one of the most important assets of any pharmaceutical company. Also, an issue that globally is it's not increasing, but I think it's constant. It's the lack of transparency that affects especially like prices of medicines, but also cost of research and development. And has a direct consequence on the information asymmetries in the pharmaceutical markets. And I think that now pandemics is part of like the array of challenges that health authorities are facing. And here I think that we have like three issues that are really important at the time and that we are going to be discussing today. One is like an effective global response, or to make sure that we achieve this universal equitable access, that we make sure that no one is left behind. Second, like recovery, what happens when the pandemic is quote unquote over? How do we make sure that we rebuild like especially like health systems? And what like some say it's like the next stage, like preparations for the next pandemic. In this sense, we're going to be talking about what's being discussed not only in terms of the P with the Bridge waiver, but also like this like pandemic preparedness response that governments are discussing and what form can it has. At the same time, we're saying like exceptional moments at the global level, but also at the European side. I think that this like for the last, I think it's like 18 months. It's not only that we've been living in a pandemic, but it has like coincided with several really like consequential dossiers at the European Union level, with the European Commission putting forward proposals on issues and topics that will have consequences for the decades to come, especially the European pharmaceutical strategy, especially the review of like pharmaceutical legislation, including like incentives for rare and orphan diseases, also the IP action plan and all the like implications for the regulation of supplementary protection certificates and other legislative initiatives, like, for example, the plan of action on AMR that tomorrow it's finishing like the open public consultation. At the same time, we have like HERA. I mean, it was really, I think it's not every day that you can see like how EU agency, that it's not an agency, but it's a substantial like assignation of resources and like political space for such an initiative on global health. And I think it's really interesting and something that we're going to be talking about to follow the evolution of HERA, and especially how do we link it with existing initiatives. And finally, I think it's interesting to see how the European Union is collaborating towards this new architecture, this new global health governance framework. And we can see it like with discussions around the TRIPS waiver, like the pandemic treaty or response that I have mentioned. In sum, what we are trying to do here today is look at the intersection of these policy processes that are going on at the same time, and how can we use or maximize like what the European Union has to offer at the global level, and how do we make sure that the European societies and civil society, most especially, are also taken into account in these global discussions. And now I'm going to give the floor to Ella Vegan. Give me just a second. I'm going to share the screen.
Thank you very much, Jaume.
Yes. Good morning, Ella. But give me just 1 second to introduce you. I mean, everybody knows you, but I think it's important that we highlight that Ella has an extended experience in influencing policy of the Dutch government, the European Union, and the World Health Organization on global health issues. And she is also, as a senior global health advocate for DEMOS, she currently coordinates the international consortium COVID-19 Innovations for All, CIFA, that encourages the sharing of intellectual property, know-how, and technology needed for the production of medical products against COVID-19. And thank you, Ella, you have the floor.
Thank you, Jaume. So good morning, everyone. Let me say that WEMOS is a global health foundation based in the Netherlands. I work as a global health advocate on the Access to Medicines team. We made a review of different global and EU initiatives for global access to and financing for products against COVID-19. And the website is called covid19response.org. The website now covers 15 initiatives, such as Team Europe, the mRNA Hub, CTEP, Medicines Patent Pool, HERA, COVAX, Pandemic Treaty, but also compulsory licensing. And my presentation today will be mainly about Team Europe, but please have a look at our website, covid19response.org, if you're interested in any of the initiatives, and do give us feedback or ask questions if you have them. We had the previous slide still, yes, thank you. We had a strong sense that a critical review was needed of all of the different ongoing global and EU initiatives, especially with the amount of public funding of billions of euros being allocated to COVID-19. Yet we continue to see persistent access inequities worldwide. We know from the early phase of the pandemic that public funds were invested in R&D without health equity conditions and allowing pharmaceutical companies to determine the prices and have a large profit. WEMOS now looks at new investments, such as for public-private partnerships in local production capacity, which Team Europe is doing, and we ask ourselves the same question. Will there be conditions attached this time? To what extent will these public funds prioritize public over commercial interest? We used 5 dimensions to assess the different global and EU initiatives. The first one is sufficiency. To what extent could this initiative help to meet the global demand for COVID-19 innovations? Then we look at urgency. To what extent could this initiative increase global access to COVID-19 innovations urgently? We looked at sustainability. To what extent could this initiative improve resilience to future public health emergencies of international concern? We looked at power balance. To what extent could this initiative contribute to equal power relations between high-income countries and lower-income countries? And we looked at public first. To what extent does this initiative put public interest above commercial interest? We do not believe that one of the initiatives that we have on our website can provide the answer to the lack of access globally to COVID-19 products. It's really the combination of a set of initiatives that contribute to the 5 dimensions
I think there's an issue with the last connection. Okay.
Hopefully she'll be back with us shortly. Otherwise, should we move on to the next speaker, Jana?
Yeah, we can do that. Next speaker is, I'm going to share the screen again.
I am back, so I don't know if it's still.
Yes. Okay.
Sorry, apologies. Don't.
Just in time. Don't worry. Ella, please go ahead.
Let me see. We looked at Team Europe. Team Europe was founded in response to the pandemic in April 2020. And Team Europe is an EU collaboration between EU countries, the European Investment Bank, and the European Bank for Reconstruction and Development to support mostly low and middle income countries in their fight against the COVID-19 pandemic. And facilitate...
Ella, that's the next slide, no?
Yes, the COVID-19, yes, it is. It's on Team Europe, yes.
Yeah.
1 second. The funding is of 46 billion euro. It aims to reach Team Europe aims to reach a global vaccination rate of 70% by mid-2020, similar to the WHO target, mainly by donating vaccines and offering financial support, for example, for increasing manufacturing capacity of medical products. Since the COVID-19 outbreak, Team Europe has financially supported COVAX with 3 billion euros for the delivery of vaccines in low and middle income countries. Next to that, Team Europe has donated vaccines directly to COVAX. In total, Team Europe has committed to the delivery of 500 million doses. For this donation of vaccines, we have a similar critique as with COVAX. It upholds the same power imbalance because of the dependency on the goodwill of Team Europe to donate. What differentiates Team Europe from COVAX with regards to structural solutions is that Team Europe has reserved 1 billion euro to support local manufacturing capacity in Africa. As well as we are supporters of initiatives that lead to increased self-sufficiency for low and middle income countries. But it is difficult to assess how Team Europe will achieve this increased local manufacturing capacity. As strength, we see that donations are necessary for the short-term relief, donations of vaccines for COVAX. Another strength of Team Europe is that it has a long-term potential. It supports local production capacity of vaccines, medicines, and other key medical products in Africa. The weaknesses that we see are that the actual delivery of vaccines does not come close to reaching its targets, similar with COVAX. It does not guarantee that the medical products produced in low and middle income countries become firstly available to the local production and for a fair price, to the local population, And there are no conditions on public funding and no mentioning of the need of sharing of intellectual property and know-how for expanding manufacturing capacity of medical products. So the efforts of Team Europe mostly focus on short-term solutions, for example, funding of COVAX and donations via COVAX. But a report of the People's Vaccine Alliance of October 2021 shows that the pledged donations by Team Europe are far from the actual amount of vaccines that have been delivered to low and middle income countries. According to the PVA report, Team Europe has delivered only 10% of its 2021-2022 targets. On the other hand, investment in local production capacity in low and middle income countries is very much welcome, but the devil is in the detail. Conditions to public funding for increased production capacity that involve private companies must be transparent and benefit public interests, such as fair pricing and producing for local needs. At this moment, it is unclear if this is indeed the case. Furthermore, in order to facilitate increased global manufacturing of medical products and reduce the dependency of lower income countries on high income countries and leading pharmaceutical companies, Team Europe should officially support initiatives that arrange the sharing of intellectual property and know-how for needed for the production. In order to judge whether the impact of Team Europe's efforts to increase local manufacturing capacity is really for the benefit of the population of the African region, remains to be seen and is highly dependent on the details that still have to be published. WEMOS will research the investments of Team Europe in Rwanda, which will be in a cooperation with BioNTech. Team Europe is also investing in other countries in Africa, 9 in total, which are Morocco, Egypt, Senegal, South Africa, Ghana, Nigeria, Ethiopia, Kenya, and as mentioned, Rwanda. As WEMOS, we recommend that any funding that will go to private or public institutions in order to promote local manufacturing capacity should come with strings attached. These conditions of this funding should promote regional access, affordability, and transparency of prices and R&D costs. I will share some links in the chat about the projects of Team Europe and the news on Team Europe and the challenges that are found. For now, I would like to leave my presentation at this, and thank you very much for your attention. Please let me know if you have any questions.
Thank you, Ella. I think that there were like a number of points that will be very interesting to follow up on the questions and answers after all the presentations. But I think it's really a really good start for this public discussion. And now I'm going to give the floor to Marcin Rodinka-Behele, who is a policy manager for healthcare delivery and is responsible for access to better and affordable medicines. He joined the European Public Health Alliance in January 22, and with the aim of safeguarding public interest in EU policies on medicines and public health. Prior to joining IFA, Marcin worked on health policy and global equitable access to health technologies with the Global Health Advocates and Mental Health Europe. And he also worked with the National Institute of Public Health in Poland, the Jagiellonian University, and a number of human rights NGOs. I'm going to share the screen with his presentation. Share screen. Okay, it should be, yeah, good. Okay, let me know when you want me to change that.
Yeah, you can go directly to the first slide. I think you should just click a couple of times. Yeah, that's just the title. Thank you very much for inviting IFA to contribute to this, I think, very timely and important discussion. My name is Marcin Rodinka-Behele, and I'm, as Jaume said, policy manager at IFA. And I believe that we have really no time to lose to learn the lessons from the ongoing, really multiple crises, and ensure that the public in general acts as a wise investor, which steers meaningful and needs-driven, affordable and patient-centric innovation. I think with the EU ambition to strengthen preparedness and response capabilities within the EU, address the vulnerabilities and strategic dependencies, and also contribute to reinforcing the global health emergency architecture, HERA, because that's what I'm going to talk about mainly, needs to consider several issues so that this ambition can be actually achieved. Now we know that HERA, this ambition in general, is adequately funded with a budget comparable to its US sister, but we know that HERA's budget for 2022 is reaching 1.3 billion euros. So this is really a good start. And ahead of the publication of the European Commission's proposal for HERA, we as IFA, together with the European Patients Forum, we published our joint vision for this new organization. I shared the link in the chat, but I'm happy to say that some of our recommendations that are aligned with a wider advocacy efforts by other public health groups working in Brussels at the national level and global level have resulted in some concrete outcomes and features that hopefully will make HERA better responding to public health needs and future health threats. And let me just highlight some of them that I think are, are some positive steps in the right direction. And I think these are somewhat balanced governance structure. Now we know that there's going to be an advisory forum that will have a dedicated subgroup for the civil society, which is a very welcome step and initiative from the management of HERA. So I think this involvement of patients, consumers, healthcare professionals, and other hopefully public health organizations will result in a better governance of this authority. We also know that thanks to the work plan for 2022, that HERA will do some considerable investments into areas identified as the most concerning and high impact threats. And of course, a welcome, and again, I think that's something that many organizations have been advocating for, is really that the ambition is adequately funded. So we now know that HERA has an ambitious budget. We just hope that this budget will be invested in a way that will really ensure better preparedness within Europe, but also beyond, and most importantly, will contribute to better access to much needed countermeasures. Again, not only in Europe, but also beyond. I want to say that the arrangement chosen for HERA, that the fact that it's not an independent agency and it is an authority within the service of the Commission, I think it can be discussed, but I think it allows for speedy action and substantial autonomy for the Commission. But of course, when we talk about this, we also need to keep in mind that there is a need for a high level of transparency and accountability in the work of the European Commission and HERA specifically. And I just want to recall that some of the HERA's building blocks, such as HERA Incubator or EU Fab project, have been operational since actually almost the beginning of last year. So some elements of HERA, as we know today, have been in place for quite some time now. And I think there's a kind of an agreement on that, that HERA has the potential to fill in some of the major structural gaps in the EU crisis preparedness and response infrastructure. And I think the experience gained through the negotiations of the EU vaccines contracts against COVID-19 and the exchanges and dealings with the pharmaceutical companies since the start of the pandemic fed into the design of this authority, and will shape kind of the mission of this structure. However, I think we all know, and we can all agree, that this contracts and agreements with the companies have not been perfect, and certainly did not help with securing global and equitable access to life-saving health technologies. So what can be changed? So what HERA should do better, what the Commission should do better, what the EU can do better. And here, John, I will ask you to change the slide. Thank you. So how and what HERA should do better to really, contribute to the global health architecture without acting on this Europe first approach? Because we know that again, the US kind of at some point acted very much on the America first approach, and it didn't really pay off globally. So how we can do better in Europe? I agree with what was said by the management of HERA at some point, that we don't have to copy everything from the US. Sometimes we can do better in Europe, and I agree, and I think that's one example of where we can do better. The EU's vision on HERA indeed recognizes that the value of international cooperation and the global nature of health threats, and the proposal for the Council regulation that is, by the way, still not adopted by the Council, is really permitted by the mantra of the fact that viruses and other pathogens don't know the borders, and I think we agree with that. But operationalizing this vision will, however, require that these critical medical tools that will be produced thanks to funding from HERA are made accessible across the globe. Because the EU, I think, should add to this mantra that is very much present in the proposal for the Council regulation, that is well rooted in the scientific evidence, that no one is safe until everyone is. So we really have to kind of make the countermeasures available everywhere in order to be safe. And of course, we need transparency. I think this comes without saying. So far, we don't know who's on the HERA board, for example. We know that there is a board, but we don't know who's on the board. And we are worried that this lack of transparency that we experienced and we saw during the negotiations of the contract will continue. So we kind of urge HERA to improve that. And we know that HERA is tasked with negotiating with the companies and with signing the contract. We hope, we call on the Commission to do better in terms of transparency. We acknowledge the fact that quite transparently, HERA published its first work plan for 2022, and we can see there are many important points, such as, for example, the list of preliminary health threats that HERA will potentially focus on beyond COVID. And there we have, for example, antimicrobial resistance, pandemic influenza, vector-borne diseases, and other potentially very important threats to be addressed. This will be discussed, not negotiated, but discussed, hopefully in a meaningful way with the advisory forum that will be set up. And that leads me to my next point, that what's needed, and I think that's really, we see this happening, and I think it's a great encouragement and a sign of a goodwill from the HERA leadership, that on the top of what's foreseen in the decision to establish HERA, there will be civil society forum. Now we know that HERA will soon release calls for expression of interest to join this group for patients, consumers, and healthcare professionals. So I hope this civil society forum will be meaningfully consulted, equally to the Joint Industrial Task Force, that is a dedicated seat for the industry. So we do hope that this is not going to be just a lip service, but really a meaningful place for civil society to have a say in the operations of HERA. And I think the most important points, 2 points that I want to make to finish, are that so far, unfortunately, we have not seen any equitable access policy featured as part of HERA's functioning. We've heard actually that this is not something that HERA is planning on prioritizing soon, and we think it's a big mistake, and this should be considered as soon as possible. HERA, as an authority that is supposed to contribute to the global health architecture, should have a robust access policy to the medical countermeasures that it will co-fund or fund. And I think HERA simply must foresee clauses guaranteeing downstream access and affordability of whatever is being co-funded with the public funds. We see in the political agreement reached in the Council in the beginning of this year that indeed there are some additions made by the member states, I think. So again, we encourage HERA to consider this as soon as possible. And last point is on the international cooperation. I think we know from the work plan that HERA is planning on signing, for example, memorandums of understanding with different structures, with different philanthropic organizations, but also, for example, with CEPI. We know that one memorandum of understanding is on the way. We think that this document should be, first of all, public. And when it comes to the international cooperation of HERA with organizations such as CEPI, we think that they should really go hand in hand and build a critical mass for vaccines development, but also for other medical countermeasures development. Yeah, because I think this kind of cooperation is crucial, and I think we cannot really go in the direction of health securization and kind of each region for its own. We cannot beat any health threats simply doing it regionally. And I think we need a deeper coherence between different instruments here and between different organizations globally. So again, if HERA wants to be a global player, I think it needs to strengthen its collaboration in a very transparent and meaningful way, ensuring access with global actors in the global health area. And the last thing really is that we know we have some good examples of the not-for-profit infrastructure in the development of health technologies. And I think HERA should look into it. We have a great study prepared by the European Parliament, by the STOA panel, on how the not-for-profit infrastructure can contribute to the development of medicines and health technologies. And this is something that can help to overcome market failure. Again, this is not something that is prioritized by HERA. We believe it should be. And I think if the EU wishes for HERA to become a truly global project, it will need to treat the medical tools resulting from the public investments as global public goods. There's no other way. Thank you very much, and I'm very open for questions and comments you might have.
Thank you, Marcin. I think that again it was a really very good presentation. I mean, you were really highlighting the main issues, and I can see already there's like an idea that keeps on repeating this need for coordination, this need for coherence, and really this idea that if the EU wants to be a player in global health, it has to do it from like a cooperation perspective and move away from this idea of really like that only the EU or Europe first and embrace this like no one is safe until everyone is safe. And next we have Irene Bernal, who is like Access to Medicine's Advocacy Manager at Salud por Derecho since 2015. She has been working on development policy and social policy reforms in different areas for the last 20 years, first as an expatriate in Palestine and Bosnia-Herzegovina with UNDP, also as a project manager for European social funds. And she has been working also as a social policy advisor at ministerial level in Spain, among other responsibilities. And Irene is going to be talking today about the experience in Spain with the Consejo Superior de Investigaciones Científicas and the licensing of a diagnostic with CITA, the WHO, like a pool for like COVID-19 technologies. Irene, I don't know if you want me to share the presentation or you share the screen. How do you prefer to do it?
You can share the slides I sent you this morning, no problem at all.
Okay. Give me just a second. Okay. Okay, let me know when you want me to change the slide. Have the floor.
Okay, well, thank you very much, Jaume, and thank you very much, everyone, and for letting me to participate in this conversation, in this very timely conversation. I'm going to talk about the case of a state member, Spain, and I think we get a pretty nice view from Ella and also with a specific program at the EU level that just Marcin has shown us how HERA functions. But in both presentations we have coherence and we have coordination. It happens exactly the same at a state level. We look for coherence, we look for coordination, and this is basically what we've been doing, not only during the last couple of years regarding the pandemic situation, but also in the past. So before starting, I just would like to highlight two things. First, yes, Spain has become quite known for its moves in terms of approaching CTAP and also regarding its position towards the TRIPS waiver. But this is also something that it's, from our understanding, it comes from first previous actions, meaning that we started an ongoing campaign in 2018, where we started to put in the agenda the concept of public interest, access provisions, and conditionalities into public funding contracts, but also into research center policies. So also working with tech transfer offices, trying to find out what was actually the point of departure of the research centers here in Spain, and how access provisions was perceived and seen from these main institutions. And then in second place, I think it's also important that we do have a government that was very much willing to contribute to the pandemic with certain actions and concrete steps. So I think if we conflate both issues, I think that we got a committed state, but also with its lights and also its shadows. So that now I will talk about it. So just briefly, in 2018, Salud por Derecho, we started research, basically saying, hey, we talk about public conditions and access provisions into public funding contracts, and also into public policy and public policies research centers, tech transfer offices policies as well. But what is the status of Spain? What are we in Spain? Who is really a concept that everybody knows about it. It's really public interest an issue. It's that research centers or tech transfer offices are trying to approach, or you know, what is the starting point of all these discussions. So at that point, we decided to start a research and trying to find out what was going on, basically. And well, the result is that not much. So public interest concept was not a discussed concept into the research center. Tech transfer offices, they were very much looking to, to reach certain indicators, dealing with the number of patents, dealing with how many licenses they were doing at the end of the year, how many spin-offs or spin-outs were, done or created by the universities or the research centers. So the social impact issues or access provisions were very far away from the discussions. So that actually gave us the highlights of, hey, this is really something that we need to start to discuss and to put it on the table and try to find out how we can approach in this dialogue tech transfer offices, and how this concept of public interest and how these policies of access provisions and conditionalities regarding, of course, prices and transparency issues. I mean, I'm not going to go over all that because already Marcin has covered pretty much all, how all that can be included into their policies, and also at the end can in practical terms can be in their contracts. So we some of the conclusions, just will go briefly. Some of the conclusions is that basically most of the licensing were done in exclusive basis. Most of the centers, they do have procedures and they have this model of contracts, but very much focusing on business as usual in terms of trying to get to the market as soon as possible and trying to reach business companies as soon as possible to also trying to put the results in the market. So there was a vague concept of, of what can we do in terms of public health, and how this public health side could be covered, but not really a coherent policy inside the centers. So the fact is that 3 years later, the pictures have really changed, because amid this pandemic, we've seen great research institutions like el Centro Superior de Investigaciones Científicas, the CSIC, which actually decided to license in non-exclusive terms the COVID-19 products. So this is basically the gradual change that we've seen in the narrative, that we've seen also in many institutions, that more often they actually get involved into this kind of policies more often. So Jaume, I think we can go to the next slide. So this is just trying to be chronological and to present how the things have evolved. Is that this dialogue with tech transfer offices and research centers started in 2018 when we started this research that was published in 2019. And the fact is that many tech transfer offices, they really wanted to do something, but there was needed previously certain commitment from public institutions that this was really something that could be incorporated into their policies. So access provisions was on the table, but the fact is, okay, how do we do this? But with the willingness of trying to find certain solutions and how to approach this new concept of non-exclusivity. So the fact is that in 2020 we do remember an interview that it was done to the vice president of the SIG, and she said at that interview that COVID-19 technologies are to be licensed under non-exclusivity terms. So that was, for us, that was the clear sign that what the environment and the evolving situation that we've been feeling in the last years, that basically found a moment that, okay, now the situation and I guess the performance of the institutions, we really have to find something to contribute to the solution of this pandemic. So now we do have how to do it. We do know how to do it. So that was a really first step. Then in the meantime, and that was the combination that I was mentioning at the beginning. In the meantime, the Congress and the government approved, the Congress first approved a non-binding proposal on affordable and equitable access to medicines, vaccines, diagnosis, and health technologies for COVID-19. That was really a great step, because in that non-binding resolution, it was included CTAP, the support to CTAP. It was including also the support to the TRIPS waiver. It was also including compulsory licensing, issues like transparency, and also shortages. So that was a quite comprehensive framework that it was approved by the Health Commission of the Congress. It was endorsed by 19 members of the Commission, and only 5 votes against and 10, if I'm not mistaken, abstentions. So that was quite a good picture. So we had the willingness of the Congress. So we had a government that first domestically decided, with the support of the government, with the support of the Congress, and also with our commitment to contribute to the resolution of the pandemic, they did incorporate into certain key political documents that they would support and they would endorse actions related to intellectual property. So that the end of this story is that Pedro Sanchez at the General Assembly, I think it was in September 2021, endorsing the TRIPS waiver, and also Spain launching a document that it was called Vaccines for All, where basically they went over through the initiatives, the ongoing initiatives like CETA, like the waiver, and also stating in the document the need for certain revisions of the current intellectual property system. So that was a major step, and in practical terms, what happened is that having the research centers endorsing these non-exclusive policies and having the government willing to contribute to the end of the pandemic, also reviewing the intellectual property system. So I guess you have the best environment to push forward this kind of initiative. So what we did in Salud por Derecho is okay. We've been taking a greater step at international level. So we have to take to domestic policies all these commitments. This is about coherence. This is about coordination. If we are so much willing to share with CETA and certain products, first we have to extend it to all products. That also means those that has been publicly funded but developed by private companies. And this also, it applies to, okay, from once, let's think seriously about this and let's incorporate access provisions into public policies. So this is, but this is what I said at the beginning. These are the lights and the shadows. The shadow is that we have not accomplished that yet, and still a long way. But I think that so far the steps taken by the Spanish government has been really a great sign, and we've welcomed the government in several occasions that really what should happen is that their experience should be some sort of contagious phenomenon, and other state members should follow the path, since okay, they have paved the way, and so now others can follow, and other governments and countries or research center can follow, and CETA can engage with other products, and not only a diagnostic. This is what it was licensed at the end. It was a diagnostic. The CSIC, actually, they got also the backup of the researchers, which was very important. It's important. So many stakeholders participate in this process at the end. That is the government, it's the research institutions, also the researchers. So everybody very much welcomed the initiative for sharing with CETA the LISA kit, this diagnostic. So so far. It seems it's the first experience, but hopefully others will come. So, I think that the best practice of this process is that, well, from the outside, it is slow, and in a pandemic, you cannot be so slow. I mean, you have to move quickly, and things have to be done quickly, and so that's one thing, and that's one lesson learned. But we already have a good experience. So CETA should not only continue, but should, let's say, should grow up with including not only diagnosis, but also therapeutics and vaccines. And very much to learn from what we've been capable to do in a couple of years, and how this can help to get ready for our next public health crisis. So I would leave it here, Jaume, and maybe we can go over questions later on.
Yeah. Wow, thank you, Irene. I think it was a great presentation, and I think I really like how the presentations are really combining with each other. And if we had talked before about coherence and coordination, now we are really talking about the importance of political will. And I think it's really nice, the process in the slide. I mean, the sense clearly it was not fast and it was not quick, but you see like how change happens. I mean, and how it starts like with civil society putting pressure and getting public research institutions on board. I mean, the role of the legislative body, and finally this act of like licensing to CTAP. And I think it's interesting that we talk about CTAP among like the responses to COVID-19, and the role, especially Spain has been one of these governments have been very vocal about like the need to redefine and reinterpret like intellectual property in the light of a pandemic. And I think it's all this debate that we have around the trade waiver and the position that has adopted the European Commission, which I think it's also quite worthy examining. And now I'm going to give the floor to Dimitri Einekel. And Dimitri, do you want to share the screen or do you want me to do it?
Yeah, just let me maybe talk a bit, and then I'll tell you when to show the slides if you can, if that's okay.
But let me introduce you, and I will be ready with the slides. Dimitri started with Doctors Without Borders in 2010 and has worked in health projects in Haiti, Afghanistan, Libya, and Iraq, among others. Since 2017, he has been representing Access Campaign and MSF at the European Union, advocating for affordable and better access to medicines for patients worldwide. And together with Health Action International, he's like the co-host of the European Parliament Working Group on Access to Medicines and Diseases of Poverty. And Dimitri, you have the floor.
Yeah, thank you. Thank you, Jaume, and thank you everyone for this excellent event today. And thank you to the previous speakers. It was very interesting to hear your thoughts, and I also learned a couple of new developments that I wasn't aware of. So always interesting to join these panels. So I'm speaking here today indeed on behalf of Doctors Without Borders, MSF. As a medical humanitarian organization, we work on access to medicines, but obviously our primary work is to contribute to the medical efforts worldwide, and particularly also for COVID-19, where we have contributed in patient care in about 70 countries worldwide. With the emergence of the COVID-19 pandemic, there has been a revival of efforts and discussions about international pandemic preparedness and response, which have emanated now in a discussion about a potential pandemic treaty. Now, there's a process in place of negotiations that will last until 2024. That process only started last month or this year. So there's not that much on the content of that process to say yet, because the negotiations are still about to start. But what we see is that currently the global mechanisms that have been created to respond to the COVID-19 pandemic have been branded by some as a major success. But at the same time, we have to take into account that there have been 5 million deaths, and the impact of the pandemic continues until today worldwide. We're not at the end of the pandemic yet. We have to bear in mind, or we're not sure that we're at the end of the pandemic. And from Doctors Without Borders MSF side, we have clearly seen that the international architecture to enable equitable access to technologies and products, medical products, was not developed appropriately. This despite clear calls for the past 2 years for greater equity and transparency by civil society organizations. Maybe we can quickly show some slides of what is the situation like today after 2 years in this pandemic. If you can show this slide maybe in full screen. Yeah, thank you. So this is a graph that I like to use from the Financial Times COVID-19 tracker, because I think it shows quite well the current situation when it comes to COVID-19 vaccines worldwide, the access or the administration of COVID-19 vaccines at least. As you can see on the bars on the left is low-income countries, low middle-income countries, upper middle-income countries, and high-income countries. The dark blue is 3 doses. The middle blue, if I can put it that way, is completely vaccinated, and the light blue is only 1 dose. And it results in the share of population vaccinated. As you can see, low-income countries are still around 15% of fully vaccinated, which is, more or less 1 or 2 doses, depending on the regimen. So it's very low compared to upper middle income and high income countries, as you can see, where it's largely above 70% that people have been fully vaccinated, which is the WHO target. Lower middle income countries' situation is a bit better, but still around 45%, so still a long way off from reaching the 70%. We have to bear in mind that low income countries and lower middle income countries constitute 40% of the global population. So the result of this is not, this is quite a significant number of people that still need a number of doses before they're fully vaccinated, and that we're not even talking about the boosters yet. And that is visible on the slide on the right, or the graph on the right, I mean, where we can see that the number of booster doses administered in high-income countries is about double from the total amount of doses that has been administered in low-income countries. So that means that in reality, in some ways, the inequity is still not only very present, but you could even say is still growing to some extent, and that the catch-up that needs to happen in low-income countries and low-middle-income countries is quite extensive. We have analyzed, COVID-19 vaccine procurement and supply contracts, deals, etc., from the early start of the pandemic, and very clearly there was a tendency both by high-income countries to buy up the doses, but also from pharmaceutical companies, major pharmaceutical companies, particularly the Western pharmaceutical companies, to sell a huge extent of their doses to high-income countries. To give the example of Pfizer, it only sold 2% of its supply to COVAX. That's, knowing that 3 billion people in the COVAX AMC, of COVAX AMC countries rely on COVAX for their doses to a large extent. That means that the supply of the Pfizer vaccine, which is one of the most effective ones, is actually very limited. And this has been across the board, 70%, 80%, etc., of the supply going to high-income countries rather than equitably distributed and allocated across the world. In the end, in high-income countries, only about 20% of the global population lives. 80% does not live in high-income countries. So the situation is still, quite dire, if I can put it that way, in terms of inequity of COVID-19 vaccines. Maybe if we can go to the next slide for another illustration, and that's the situation today when it comes to COVID-19 therapeutics. This is one example, but there are more. And unfortunately, you cannot see the link on the slide at the bottom, but it's a link to our website where we published this map. Can you go back for a moment, please? Can you put it full screen? So this is access to Pfizer's Paxlovid or letermovir-ritonavir combination. So as it's often called, the COVID pill of Pfizer, an antiviral treatment. Pfizer has a limited supply to produce this year that they can provide to the global population. In that regard, positively, they issued a voluntary license, so basically allowing generic companies to produce that pill as well and to supply to a number of countries worldwide. And those are the countries in green. The countries in red are excluded from this voluntary license. So they cannot access the generic version of that product. But at the same time, the supply by Pfizer itself has already been bought up until the middle of this year by high-income countries in gray. And maybe even longer beyond the middle of this year. So that means that the countries in red, they basically have no supply, at least until the middle of this year and maybe longer, to any of these treatments. And the situation is very similar for other treatments. Baricitinib, we have a similar map for baricitinib, which voluntary license is only issued to India. So only for the Indian population would get access to generic treatments. And there as well, there's limited supply and high prices for some of these treatments. And we just have to remember that this is important for people that already fall ill of COVID-19. So it's really important that people can get on the right treatment in order to avoid hospitalization and inevitably maybe even death. So access, particularly in countries where it's lower vaccination coverage, is really crucial to prevent major impact on patients, I would say. So these were just two illustrations that I wanted to show, but in the end, what we have seen in the global COVID-19 response is that to a large extent, there were opportunities to challenge the status quo, but what we have seen is that to a large extent, non-medical interests have been prioritized to the detriment of equitable access to the distribution of these tools. And in that regard, we are quite concerned about efforts by high-income countries and the European Union that are currently advocating to make the global mechanisms of the global response to COVID-19, such as COVAX and ACT-A, as permanent ones. We see that the EU and high-income countries are contemplating how to make these systems relevant between pandemics. But the question should rather be, how can we make them more relevant, or should we not have more relevant structures and systems in place during a pandemic? I think that should be the first question. And we have not seen a proper evaluation yet of these rather opaque systems. Neither is the question asked if these systems are actually sufficient. The systems were largely based on pooling of demand, but then left it up to the markets to see where the supply would come from. And we have seen competition in the end between a pool demand of low and middle income countries with high income countries, and they can never outbid the interests of high income countries in reality. And so we could see in a way that COVAX has been undermined by the very actors and powers that helped to create it. COVAX only delivered about half of the doses they intended to deliver last year, 1 billion instead of 2 billion, and half of this 1 billion were donations. But you can't have a global response to a pandemic based on charity donations and philanthropy, which is to a large extent what has been done. And what we have seen is a disempowerment and disadvantagement, a disempowerment and disadvantagement of low and middle income countries in these systems, because they were to a large extent kept out of the governance systems. The governance of the global response to a large extent was relying on the G7, which is a very limited number of countries, rich countries in the world, as well as some private actors, as the World Bank, unaccountable institutions and organizations like the Bill and Melinda Gates Foundation. Those have really driven to a large extent the pandemic response. So in that regard, it's quite important and interesting that now with the discussions around the pandemic treaty, we have a different forum. We have the World Health Organization and the World Health Assembly, which is really representing every individual member state where they can express their views and come and work towards options and solutions which are hopefully better and more equitable and more inclusive towards than the response that we have seen right now. Where another major limiting factor, maybe we can remove the slides that they don't distract, but to another extent of what we have seen right now is a large reliance on, I already mentioned it, market dynamics and corporate goodwill. I mentioned the examples of voluntary license of Pfizer's COVID-19 pill. We have very limited licensing actually of COVID-19 vaccine production by the major producers. This reliance on market dynamics is quite regrettable, because it was already clear from the start of the pandemic that there would be an acute shortages of supply of COVID-19 tools or any medical tools that we needed. And this was also raised not only by us, but there were about 30 members of the European Parliament that already wrote to the European Commission in March 2020. So that's about the time that the pandemic hit Europe. They already wrote to the European Commission to issue non-exclusive licenses for products that would be developed, particularly the ones that would be developed by EU funding. There was also a letter by NGOs, civil society organizations, about 80 civil society organizations in June that same year, calling for technology transfers across the globe to make sure that there are production sites everywhere. That was before any of the purchase agreements were signed, before any of the vaccines were actually, finalized in their development. Already these points were raised. The points that we're still discussing today, 2 years later, technology transfer, intellectual property rights barriers, etc., were already raised at the very early months of the COVID-19 pandemic. So the European Commission could have known, but chose not to address this. and to choose an option where despite the massive public investments and upfront payments, because it's investments and payments by the European Commission and high-income countries, they stick to a medical innovation model that does not necessarily address patients' needs and does not serve the urgent public health challenges. These were economic interests that continue to be dominated over public health interests. And that was actually still, if you read the European Union vaccine strategy, it was there. It was already there. You could see how the European Union was saying, we will produce COVID-19 vaccines for our own population and for the rest of the world. But they didn't say, we're going to help the rest of the world to get vaccines and produce them. They said, we will produce them and export them there. If you read between the lines, that is what is there in all the communications across the board. And so related to that, you could see that there's, Anna already mentioned that there is a Team Europe initiative for 1 billion investments for production of COVID-19 vaccines and treatments in Africa. And of course, this is a welcome effort, but it's insufficient and it's too late, to be honest. It was too late that this happened. Plus, it ignores the reality that while the Commission now says we are going to build production capacity in Africa, that there is production capacity for COVID-19 vaccines. We identified more than 100 companies together with other experts and NGOs that can produce COVID-19 vaccines. So while it's, of course, a laudable effort to produce more capacity in Africa, the reality is that this is maybe not the right approach to just build more capacity, but rather help to make sure that these capacities can be used. And for that, you need technology sharing, and you need to address the intellectual property rights barriers. And this is where I want to come to another main point in my statement here today, and that's the context of the TRIPS waiver, which is a call by more than 60 countries, or actually more than 100 countries supported it publicly, to temporarily lift intellectual property rights on all COVID-19 products, so vaccines, diagnostics, and treatments, at the World Trade Organization, so that they can be more self-reliant. And that is within a context of them being completely dependent on a system they don't identify in, that they don't feel recognized in, and that hasn't served them very well. That they said, we want to have our own options here, that we can produce our own tools and offer them to our patients and our populations itself, and also collaborate with other countries who are in a similar situation. And this has been very hardly resisted by a small number of countries or regions, including the European Union. Unfortunately, the European Parliament is in favor. It voted 3 times a resolution favoring the TRIPS waiver. But the EU kept ignoring all the evidence of intellectual property rights existing on COVID-19 vaccines. The mRNA hub is now at risk of being blocked by patents by Moderna. The treatments, I showed you example of the Pfizer COVID-19 pill. I could also use remdesivir very early on in the pandemic. That was also not available for half of the global population, and so on. Now, maybe on that point of the TRIPS waiver, last week there was a document leaked, a negotiation document leaked. It was erroneously and misleadingly presented as a compromise. It turns out that this was a text that was still under discussion at capital level on whether to endorse it or not. So it does not seem like it is a compromise. It's a text to be discussed for a potential compromise. But what the document clearly is very clearly, it's aligned to the European Commission proposal, which is we change almost nothing, and remains very much limited to vaccines, not to treatments. I showed in the slide to the problems with treatments, and not diagnostics. And it contains some really problematic clauses as well that could actually potentially undermine existing flexibilities in the TRIPS agreement for better access to COVID-19, or not only COVID-19 tools, for any public health tools. So that's just to say that it's really a pity that the Commission still sticks with this very narrow proposal that does not really help, and seems to be pressuring countries at the moment to adopt and accept this proposal, which is very far removed from the TRIPS waiver that was initially intended. So I will not speak too long, just to make sure that we have time for Q&A. But in short, there is a clear rethinking needed of public health or the global pandemic response and preparedness towards the future. That will need to be based more on self-reliance, self-supporting local and regional initiatives, and helping others to take care of their own needs rather than remaining dependent on the interests of donors, major pharmaceutical companies, etc. So let me stop on that note.
Thank you, Dimitri, also for being able to put so much information in such a short space of time. I think it's really interesting. Also, like what you were like showing us with that map of those countries that are being excluded of voluntary license mechanisms. I mean, and also that reflecting on that initial position of the European Union regarding like vaccinate the world, and like the later position regarding the waiver. I think it's really interesting. And again, it's that triangle that we are talking about today of like coherence, cooperation, and political will that it's at play. So we have like 70 minutes for some questions and answers. I have prepared some questions ourselves, but I think it would be interesting to hear like some of the participants, like hear what you think, like the reactions. When you ask, if you can introduce yourself, your organization, and the speaker you would like to address. Thank you. Okay. Tom Cornu, you have the floor. If you can, oh, perfect. Please have the floor.
I was just wondering, we had a report for the European Parliament from the STOA panel on the public infrastructure to deal with the problems you all mentioned. And I was wondering, I don't know for who the question is, but what do you think about that? Would that be a solution, or is that just an idea that won't solve the problems either?
Sorry, can I ask you clarification? Do you mean public infrastructure? I don't know exactly. I don't have the full knowledge of the report, but is it public infrastructure for production? Is that what you mean?
So it's really public infrastructure for R&D, but it's for the whole pipeline. So from research going until production. And they said, yeah, you can do it in different ways. You can have a small scope with only working on the countermeasures for infectious disease, etc. Or you can have a larger scope that it also covers more the rare diseases and things like cancers. And the idea is to deal with the market failures.
Yeah, I can try to take that. I can try to take that just to say that I mentioned this report by STOA panel that was published not so long time ago, and it's quite a comprehensive big report that really looks into someone shared a link in the chat in the policy options on how public infrastructure end-to-end kind of could help in addressing market failures. And I think it's a topic that really gains more traction politically. We have some examples from the national level, and maybe Irene can tell more from Spain. We had some example of a therapy developed in France by the public institution, in Spain by the public institutions. I think that this is something that should be considered as an option. I'm far from thinking now that it can be a silver bullet, but I mean, it definitely can help. And I know that there is some appetite also from the European Parliament to organize a discussion on this in the coming weeks on this public infrastructure. And so yeah, I mean, just to sum up, I think in my opinion it can be a solution. It definitely should be looked into. I think it's already tested at the national level to some extent. It's been recognized by the Council in the conclusions in December last year that this should be also something that should be looked into. So yeah, I think it has a potential. It has definitely potential to contribute to the development of new technologies and address some of the market failures.
Maybe if I can make one addition. I think I mean, I haven't read the report, so I will not comment on the specific, or I haven't read the report yet, I should say. I will for sure do it. So thanks for flagging it. But yeah, I'm.
Dimitri, we lost you.
Yeah, I think that when he said that he hadn't read the report, the internet failed. He will come back, but I don't know if, yeah, okay, Irene, can you take over?
No, just simply to add that there are great experience at national level. And I think that based on that, things can really move on at the Commission and at the Parliament, because that's the case in Spain. There are great cases regarding advanced therapies, and but depending also of the type of process or the type of medicines that we think on. But there are indeed experiences that they are worth of taking a look and trying to think broader in terms of the EU level, because they really have great results and can definitely be a good practice.
Am I back?
Yeah. And
Okay.
Dimitri, and then Tom.
Yes. Okay. Thank you. So yeah, I think for sure it's an interesting idea. I don't know how feasible it is across the board, but I think in general, I mean, for example, as part of the European pharmaceutical strategy, we also asked for a pilot study just to identify, first of all, how much public funding there already goes into research and development, and how it's being allocated, where is it used, what does it lead to, etc., and map that out, and then to try to find ways how to better use and leverage those investments. I think I would not completely, cut out, the work of important biomedical companies, particularly SMEs, who are really doing, financially risky investments in technical, biomedical technical innovation, etc. So we can work with that, but it's more how to better, ensure the public interest into the investments that go into this, and how these investments can be used to, as I say, to protect the public interest in that regard. And I think to some extent, even some companies can be used as service providers almost, that they provide certain technologies that can be used by HERA and adapted, and platform technologies that can be used for a wider, range of disease. It doesn't have to mean that the ownership rights remain with this one biotech company alone, because that's exactly what we have seen with COVID-19 right now, with mRNA technology that is now in the hands of two companies, and we're stuck with them basically. So that's I think there's multiple ways that we can look at these issues without necessarily only having to rely on public research and development institutes, which doesn't mean that they need to be excluded either.
Thank you, Dimitri. Tom, did you have a comment, or no? You're good. I want to a comment on something that it was said, like responding to Tom's question, but we say there's no silver bullet. I mean, it's clear that there is no a sole intervention that will solve the issue of access to medicines or access to innovation. But I think that there are some interventions that are counterproductive, and I think that it's very clear that if we don't have a very a clear accessibility policy, that we don't have guarantees for public return on public funding, if we don't have and we need to have it enforceable, non-exclusive licensing of public funded research. I mean, these are really obstacles. I mean, and not having these, it's already making it things much more complicated along the way. And I think that what Irene was mentioning, I think it's really interesting what we are seeing with CAR-T therapy, especially in Spain. There are some really very interesting cooperation, public-private partnerships, especially with public leadership, which I think, I don't know, I like to be an optimistic, can be the way to go when it comes to mRNA technology. In the sense that I think it's known that mRNA technology, one of the uses, it's for COVID-19 vaccines, but there can be many more. And that's the fight that we are really fighting now. We're not fighting not only for the vaccines, but also for the future of this technology. Okay, I'm wondering if there are other questions or reactions or comments.
Can I respond to it as well?
Yeah, please.
Yeah, I think it's an interesting question. I just put in the chat an overview of the interviewing research of already public funds. So I agree with Dimitri that there's already large amounts of public funding going into R&D, but also into advanced purchasing agreements, etc. So I think that should be better monitored and looked at. How can we condition these public funding? But at the same time, there are areas where we need public investments where no private companies will invest in, for example, in development of antibiotics. So I do think it is necessary for the governments to steer the direction of R&D research. So I do think it should come from both ways. And but as a better solution, also we think we should look more critically at how to reward innovation with the current system with patents, which is hard to overcome. I think rewarding of innovation is not working in the best interest of a lot of people, and we should think of other ways to reward innovation of new products, so pricing funds, etc. So this is my my take on public investments, which are, so I see it as very important, but there are other ways also to steer better development and innovation.
Tom, you go for.
Something I was also worrying about when I hear the discussions now, and also with this small seminar, we're always, when it's about lessons from the pandemic, it's a lot about access to countermeasures, etc. But it's all about health security a bit, and less about the right to health. Then I'm sometimes worried it's an easy focus, and like in the pandemic treaty and all, I think it will be a large focus and everybody joins that focus. So I'm a bit worried if we all do that, then we won't have the bigger picture of the right to health. And it's also a focus that will have a lot of counter reaction, etc. So I'm a bit worried if we put a lot of energy in something that won't succeed, and maybe it would be better to have more the focus on the right to health and etc.
Thank you, Tom. Yeah, this is like a big question in the sense that when you really invest like a lot of effort on something that it's unlikely to happen, I mean, it's really like choice you make, no, and the priorities you have. And I think it's different when it comes like with its public resources or when you are like defending public interest. And I think it's really going back to the idea of like public, like pharmaceutical manufacturing, for instance. I mean, let's also bear in mind that was not that strange like 30 or 40 years ago in countries like Italy, in countries like Spain, for instance. So it's like something that, well, I think it's worth the explore. And Dimitri?
Yeah, thank you. I think it's a good point. I think that, I mean, for sure, the discussions about the pandemic treaty are larger than that. I think actually there's a tendency of trying to keep the equity discussion very limited to a large extent, because the discussion is still open about the current response on the equity side. That's why it gains a lot of attention. But I'm not sure how much it will be present in the final outcomes of the pandemic treaty, everything related to that, because there are multiple processes. But I agree with you for sure that there has to be more than that, and particularly, you know, the whole global health security narrative is not helpful, because it's largely, you know, the security of the response rather than the preparedness and as you say, the entire response. And we need to question as well the whole surveillance system, etc., where currently what we have seen, it was already the case with the Ebola outbreak, those that declare an outbreak are actually penalized. And this was the situation that happened, for example, just recently with the Omicron variant as well, with South Africa saying we have a new variant of concern, and suddenly everybody shuts its borders, they risk investors to run away, etc. So this is what needs to be questioned as well. We need a system where it's actually fruitful if you declare we may have a problem here with a variant or a virus that we identified, and that there's you know, positive impacts related to that rather than negative impacts. And so for sure there needs to be discussions related to all these elements. I completely agree. I limited myself on the pandemic treaty now today because we were discussing equity. You know, that was the main topic of discussion, so I kept a bit limited to that, but I agree that there's more to be discussed than we do in this panel today.
Thank you. Thank you, Dimitri. Adrian, you have the floor.
Thanks, Jaume. I'm Adrian Alonso Ruiz. I'm a researcher at the Global Health Center in Geneva, and I wanted to echo one of Jaume's comments on the relevance of new technologies for pandemic preparedness and platform technologies, especially with relation to biosecurity, looking at access in the future. I think what we are discussing today is not actually access to countermeasures today, it's actually access to technologies in the next 40 years, looking at the new technologies that have been developed. And I was wondering if the work that has been done and presented by Irene today with Salud por Derecho, working with research groups and councils and other institutions like tech transfer offices and so on, has been replicated in other member states in Europe, and if that's a potential way forward to, kind of change the narrative of the only solution for research groups is to spin out a company, look for private funding and private equity, and generate value for stakeholders, for shareholders, sorry. So I see some kind of potential to change this narrative of value generation only for the private sector in research groups and tech technology transfer offices. And I'm wondering if there's some work being done by other civil society groups in the Alliance. Thanks.
So thank you, Adrian. So there's a response on I know that like SOMO in the Netherlands have been looking at this issue, especially of like equity funds, like investing in pharma and what consequences it has had, no good. But I'm not aware of other groups working on it. Irene, you have the floor.
Well, I think that the Buko Pharma in Germany, they've been following up very closely licensing procedures in Germany, but it's really an open field. I mean, it's definitely a window of opportunity to approach tech transfer offices and trying to listen and hear what they have to say, because sometimes just simply don't know. Sometimes they just simply don't have the time, and they're basically overloaded by already a whole bunch of stuff going on, and they do not have all the resources they need. And so it's definitely a field that we should explore, because the more that you get involved with the offices, the more that you give us the chance to find solutions, how to non-exclusivity can get into their, let's say, narrative common agreements, and the more they really is in their best interest. But we're talking about public institutions. We might not forget that a lot of money is going to private companies, and that's another issue.
Thank you, Irene. And you really had the last word of this event. We have come to the end. And I would like to thank all the speakers and all the participants. I think it was a really good discussion. We will distribute the link and also the presentations. And I think it can be a really interesting input for like the ongoing discussions. And also I would like to thank my colleagues that helped like organize this event. And well, thank you all. I'm going to close it now. Thanks.
Thank you.